I'd like to now introduce Dr. Ricky Polycove. Sorry, this is an outdated picture, but you will soon see that she's gone more natural with her hair, so that this is her from maybe last year, 2 years ago. Dr. Ricky Polycove. He is a respected doctor who's provided care to patients over 35 years. She's a doctor at San Francisco Integrative Health, and she's a strong advocate for patients in promoting reproductive and sexual wellness through integrative healthcare, consumer and clinician education, advocating disease prevention, understanding available treatment options, and patient empowerment.
Welcome, everyone. It's a delight once again to get to be participating with every woman and person who's interested in women's health. My books on the left, 2002 Mother Nurture, was a collaboration with a PhD psychologist, Rick Hanson, who some of you may know. He's become a pretty famous Buddhist teacher, but is also a wonderful therapist and family dynamics counselor. His wife, Jan Hansen, is a licensed acupuncturist and nutritionist. And so that book was to inspire women to take care of themselves while they were mothers, not waiting until they were kind of a self-neglected train wreck when the kids went off to college. The next book I published for the public is The Pocket Idiot's Guide on Bioidentical Hormones, which is my attempt to get good facts, actual evidence-based medicine into the hands of the public. And it's now available as an ebook, and basically find out what the right hormones can do for you. You're going to learn tonight too. I just have to give one more rave about the photo you see, the little bit here. That's the North Tower of the Golden Gate Bridge, which I was honored to be invited to take the elevator up, which takes about 7 minutes in a little teeny space. This is pre-COVID. And I took that picture myself with my cell phone. So the next slide, let's see, it's not wanting to, there we go. So up at the top, you can see an old picture. It's from a book from the 1800s. And I just thought it was kind of amusing because you can see on the far left is a baby, and then a little girl, and then the young ingenue, and then the bride. And then of course the bride then has a baby. And then there's the grandmother looking on. And then you see the old ladies all bent over on the far right. So tonight, we're going to discuss gender aspects of the reproductive system that make this picture rather unique to women. And as simple as it is, I often say to patients, have you noticed that pregnancy only falls on one side of a heterosexual intimate interaction? So yes, we all know this, that men are never vulnerable to the ravages or the delights of pregnancy. And so if we're going to be in a heterosexual relationship as a female, we have these challenges. We have to think about this birth control concept, and then the use of hormones to just better my moods. I just saw a lovely tech programmer today who was here for pretty disabling PMS. I mean, she's awesome. And then, 5-6 days before a period, the first few days of, she's just foggy brain and can't do her job. So, these are unique to women, and you'll see a picture in a minute, just how unique. And so then we have this other major boomerang that comes and gets us, whether we want it or not. If we live long enough, we'll have menopause. And then our, option is to individualize what therapeutic choices we embrace throughout our life cycle, from the reproductive years to later menopause and beyond. In fact, last night I had a dream. It shows you that even though this is not my first rodeo, I'm still like really in it and thinking about it. And my dream was that I was kind of in an argument discussion with a doctor who's a bone expert. And we were talking about estrogen as a bone agent, which in fact it is. It does preserve bone and prevent osteoporosis just as well as the bisphosphonates. And this doc was talking about bisphosphonates like Fosamax and Boniva. Isn't this a waste of a dream? Anyway, and so I was trying to convince him, yes, but Estrogen preserves her muscle mass and also helps her skin and also allows her to retain her sexuality and function without pain and body composition, and it's good for the brain. Anyway, so I woke up with that dream. So we're going to discuss all these things tonight. And then, of course, very important is our family history. What genetics did we inherit from our family? But then epigenetics. What are the lifestyle choices that we have made that either may suppress bad genes, like, you may have a parent that had high cholesterol and heart disease, but if you exercise and you've watched these factors in your own health, self-care, this may not be a problem for you. And so a big part of what guides our actual outcomes is not just our inherited genetics, but our epigenetics. And then the profound differences in body aging between women and men. I kind of alluded to that, but we'll touch upon that in a little more detail. And then what I hear and see every day, which is women's concerns about aging, dementia, cancer, and disability. And just one little obvious
Dr.
statement.
Polycote,
Yeah.
I'm really sorry to apologize. And I was wondering if you could speak closer to your mic.
Sure.
We do have live captions on, but I think that
Okay.
it's still a little hard to hear you.
Okay. Maybe this will help. Is that better?
It sounds a little bit better to me. If anyone in the audience would like to give a thumbs up or maybe let us know. I think that we can move forward.
Okay.
Thank you.
All right. So the concerns of aging, dementia, cancer, disability, these are not ill-founded, especially if you're a woman. So my last comment was that the cultural norms of our culture, which is kind of about productivity, not about self-care. And so this is a constant chafing conflict for many of us women who want to be a good employee, want to be a good partner, but in fact, finding time to take care of ourselves is really a challenge. You have to make time to take care of yourself. That's what I've learned. So just a little trip back to embryonic stages. I chose this picture on the left there just to kind of share with you the awesome, amazing guidance of protein synthesis and then embryonic development that is just built in. This miracle happens with incredible perfection the vast majority of the time. So we get born. Most of us have been very fortunate to have, the four-chambered heart and, good digestive tract and a whole bunch of things we never think about because they just work just fine. But evolutionarily, we actually are very recently departing from our natural past in terms of living so long. So a big problem with our public health data right now is that we have not, and I say we as a country, we as a public health, we as physicians and healthcare system have not acknowledged the fact that the average life expectancy has increased by 30 years in the last 100 years. So in 1800, the average life expectancy for women in 1800 was 32. By 1900, with cleaning up the water supply, putting sewage underground, a few very straightforward things, hand washing, the life expectancy by 1900 rose to 49. So even 120 years ago, only half of women would live to become menopausal, and the vast majority of us were dead by 75. So what has happened is we now live 30 plus years after menopause, which average age of menopause is about the same. It's actually 51. So what are we doing differently to live 30 more years without the natural hormones that kept us vigorous and healthy as younger humans? The addition of salt, sugar, and fat to our quote average American diet, where a lot of women have never been exposed to just plain food like out of the field. I grew up in a family where my mother boiled beans herself, not even canned beans because they were cheaper. And you'd go to the natural food store. There were some in the Bay Area, even way back in the 50s. And, it took you 2 days to boil garbanzo beans and get them soft enough to eat. But I mean, I had a very unusual exposure to cooking everything from scratch, which, of course, these days, most women would be pretty hard pressed to know what to do with the actual dried bean. And that is changing, of course, but most important is to appreciate that what seems normal in our food supply today, whether you buy at the grocery store or go out to a restaurant, is highly transformed from the olden days, which is really our gut was designed to handle very basic food. The sad fact for me as a healthcare provider is that these disease burdens are very asymmetrically levied upon women and especially women of color. So I didn't include these slides, but if I am invited back and people want a little more depth of what happens to minority populations over the last 30, 40 years, we can look at women and see the nasty bars of diabetes, stroke, heart attack going up and up. And unfortunately, the highest bars are in Hispanic women, and then Black women, and then white women. But all three categories of women have increased. So, to me, for all my years of participating in medicine and integrative health and passion for, self-empowerment and healthy lifestyle, it's pretty disappointing to see these data in the New England Journal, Journal of the American Medical Association, in addition to the Menopause Journal. So with our longer lifespans, it becomes increasingly important for us to think about, well, what are we going to do when we get old ourselves? So we have a whole new thing. I'm sure you're all aware that there's a lot of sales and marketing going on. Personal care products are really off the wall, all kinds of things that have really not been proven. I get asked about laser treatments for the vagina, at least one person every day. Again, this is marketing. The personal care aisle at the grocery store with Depends, diapers for adult continence. These are things that, 20 years ago, that was not at Safeway. So I like to inspire my patients and all of you on the webinar tonight to think about health span, not just lifespan. So in short, what the Boys Club has is they have hormonal continuity. They make sperm and have their capacity to fertilize an egg their entire lifespan from adolescence to very old age. Men really are never biologically inconvenienced by pregnancy or menstrual period, as you know. They do not have acceleration of aging in joints, arthritis, or skin. Of course, any woman who's on this webinar who's of a certain age, we all experience how different it is to, look at the chin and the neck of a, 50, 60-year-old man versus the average 50 or 60-year-old woman. The Girls Club, we have these profound hormonal and societal changes. And I put in the societal meaning, am I single with a child? Am I single not with a child? Am I coupled with a child? So we have these different identities that generally, if a child is produced in a relationship, the woman who carried the pregnancy is sort of like tag you're it. So you don't have to be terribly attentive to the national database of politics and funding, but we say that if we supported single mothers with children, we would cure child poverty, because that also goes along with motherhood. So I don't just see these things as health issues in the abstract. I see them as embedded in a whole society that does not really support motherhood and, as I said earlier, self-care. In addition, of course, if you're cycling, there's premenstrual syndrome, there's the pain, the cramps of periods, there's menstrual blood, what I call the issues of menstruation, and then the future medical concerns of aging, which are really unique to women. Yes, men have prostate cancer, but it is much less threatening socially than the cancers that have become basically forces that paralyze women with fear. And so we will talk about breast cancer further tonight, just to name it. And for all the younger people on the webinar tonight, if you live long enough, you will experience menopause if you're female. So this graphic is one, and I think our webinar little black box, I can't really move it. Maybe I can move it to the other side. Okay, let's do that. Perfect. So I want you to see the far right-hand side of this bunch of squiggly lines, because this basically starts out from birth on the far left and then goes all the way to age 82 on the far right. So what you're seeing here is an average of hormones through the lifespan of male and female humans. And so you see a little blip after birth because babies have their mother's hormones when they're born. Most people don't think about it, but you are bathed in extra hormones as a little fetus. And then you can see the hormones sort of flatten out there. And then when adolescence strikes, you can see the hormones rising for both males and females. And they are at, on the far left, what that curve is labeled as is sufficiency. It's not really a number, it's the percentage of optimal that is maintained through those years. So you can see the red lines, which are women, and the blue lines, which are men, are fairly steady on from adolescence around age 12, 13 to, for women, about age 45, 47. You can see it climbing downward at age 50, 51. Whereas men, these blue lines, they just stay steady. They lose a little bit of testosterone, a little bit, about 15% drop by age 82. So this is a huge important difference, because what happens to women in this time period when their hormones are falling, they're not getting blood tests. No one's telling them, oh, be on the lookout because you might feel like your brain is not working. You might stop sleeping. You might be hot flashing. You might be grumpy because you haven't had a good night's sleep in weeks. You have many things, joint stiffness. These are the common complaints. But unless we as providers, educators, educate women when they're in their 40s, maybe even the late 30s, that this is going to happen. If you're lucky, it won't be a big deal. But many women who see me have never had a conversation that really helped them understand that many symptoms, like the joint stiffness, I see women who've seen arthritis doctors, that this was from decreasing estrogen levels that decrease the amount of fluid that we produce inside of our joints. It's every joint, but stiffness of the hands is a major complaint. The knees, the hips, the back gets stiffer. So our joints desiccate or dry out. So do the intervertebral discs. Like, who cares? Well, if you used to be comfortable in your body and you're not anymore, you care. More importantly, we now know that these same changes can result in low mood, women who had premenstrual syndrome, PMS, PMDD, bummed out, dysphoric before the period. They often have postmenopausal dysphoria or sadness or depression. So women with postpartum depression are at high risk for postmenopausal depression because both states are low estrogen states. So I spend a lot of time on this picture because it is a very bold and, I say, brutal truth, because men's estradiol tracks along like this their whole life. And if you do a blood test for men, it is true. It is about the same from the time they adolescent in age 20 until they're 80 something. So they never have hot flashes, and they also don't have the rates of dementia that women have. So on this slide, I just like to say on one page, and I chose a walnut and the kernel of truth here because I'm from Walnut Creek. But I think it's very helpful to sort of get the crucial nitty gritty about different stages of our lives and things that most of us have never thought about. So my question is it natural to have 300 menstrual periods in your lifetime? So my definition of natural is pretty much what happened to women in Stone Age cultures. That's really natural. The next closest thing to natural is before any drug development happened. So that's up to about 1800. By the 1800s, doctors started grinding up basic parts of animals, like the pig thyroid became how we supported low thyroid. They ground up testicles from sheep and goats and cows and pigs, and they were used for various, let us say, hysterical conditions in women. So, but that didn't happen until about the mid 1800s. So I'm talking early on. What happened is that women were either having a menstrual period, but usually they got pregnant because by the time they had their first period, they were often being paired in a match. Age at union or marriage was much younger then. And so you were either pregnant, having a miscarriage, nursing a baby, or you were dead. Because remember, in 1800 in the United States, our average life expectancy was 32. So having a menstrual cycle every month, so if you're really regular, that's 12 a year. I was giving a discount here because if you started your period around age 13 and you're still menstruating, excuse me, 30 years later, that would only be 43. So in fact, women with IUDs have more than 300 menstrual periods in their lifetime. So I like to present the medical data that in fact in reproductive age women between 15 and 50, that's sort of the group I decided, all right, we'll go for those 35 years. Let's go like that, by the way. It turns out that all these years of women taking, quote, the pill have reduced uterine cancer and ovarian cancer to much lower levels, and the rate of decline relates to the number of years of contraceptive hormone use. The other thing which is interesting is most women, 85% with PMS or premenstrual depression, they will also be significantly improved on contraceptive hormones that give a hormonal continuity probably to the brain. The other thing, which is much less frequent in women on birth control hormones, is anemia, of course, because the amount that women actually bleed with their period is so much lower. The good news, which we did not know in 1960 when the pill was released, but these do not increase breast cancer risk. So every year in the United States, you can go to the NIH database and you can see the listing of various contraceptive choices. They list the various progestins. There are a bunch of different ones that are combined in all different brands of birth control pills that you can imagine. So anyway, they do not increase the risk of breast cancer. So all of this has gotten buried in the last 10 years with the incredible uptake of intrauterine devices, or intrauterine systems is what they're called nowadays. These are great methods, the IUDs, because they're there whether you thought about putting it there or not. I mean, in my generation, the pill was new, and so the big innovation was the diaphragm that our mothers used, as opposed to abstinence or foam or condoms alone. So all these things that we just take them for granted because they've been around so long, but it's important just to know there is reality when you continue something over many years in terms of collecting data, seeing this science as it evolves. So my concern, and I love IUDs for the right person for the right reason, but they don't help with acne of the skin. They don't help with PMS, and they also if women have terribly painful periods, the ones that have a little hormone in them, the Mirena or Liletta or its cousins, Kylena and Skyla, they may make the period a little lighter and cramps a little less. But again, as someone who's been in practice a long time, it saddens me when women have a history of bad PMS and then they get an IUD like their girlfriend and no one really advised them that now their acne is going to be back and they might have depression and other things that they battled, which they forgot about because they've been on the pill for a long time. So just things to think about in the reproductive age group. And by the way, the premenstrual syndrome generally gets worse as we get older. It's not like we outgrow it. It tends to get worse because our hormones get more irregular and cranky, so to speak. So the other aspect of the pill, which turns out to be very important for many women, because a lot of women, like the new patient I saw today for PMS, she's 35, she's been married for 7 years, but she and her husband are still thinking about when they want to have a child. Well, when you want to delay childbearing, the best thing you can do for your fertility is to be, in fact, on contraceptive hormones like the pill or the NuvaRing or one of those options. So again, who's going to talk in depth with our patients about this? It doesn't seem like anybody is doing that. And the patient who really wants information could go to Planned Parenthood and probably go to a group discussion and learn a lot more than the average, and I'm not criticizing all docs, but the average clinician just doesn't have time to go through the big picture, the short term. And of course, you might change health plans. So I'm not going to see you 20 years from now is the other problem with our healthcare today. But the gender specific issues for women are not just limited to contraception. We have these rare but interesting developmental differences. We call them anomalies just because the standard uterus, we've all seen the picture with the little fallopian tubes and ovaries, but there are some differences. Well, today we have many solutions, including surrogates for pregnancy. We can fix abnormalities of hormones. We can fix most of that. And another newer aspect of women, or I should say gender identified females today, is the fluidity of that definition and that experience. And I've always been very comfortable taking care of transsexual females and some males who are in the process of becoming more feminized. It's a science just like other aspects of OB/GYN. And to me, this is sort of accelerated by the information glut on the internet, but it's also kind of beautiful for people who are born with genitalia that are not totally female or totally male by standard criteria. So the intersex, and I'm actually part of a panel in a human sexuality PhD program in December on just these issues of what's the history of developmental differences, how does society treat them, how should parents treat it. Anyway, it's a very interesting and very highly evolved field because of very detailed ultrasound. But in our thinking today, I think it's nice to appreciate that what is straightforward to one person may not be so straightforward to others. But we can screen, luckily, for these reproductive system cancers. And I think the tradition of screening for women is well ingrained into our healthcare. We think about pregnancy, whether we want to have it or whether we want to prevent it. And then our breast health, I'm an advocate to start breast cancer screening with mammograms at age 40. And then, of course, I know the data and I can share with everybody, but it's clear that we have more women years of life saved if we start early, meaning age 40, and if we screen annually from age 40. And the differences in the screening suggestions, recommendations by various society really have to do with the goals of women years of life saved and what that costs either the health plan or the country. Obviously, I'm an idealist. I want to save every year of women's lives. And then as we age, the next to last line, the menopause, managing symptoms, and protecting against bone loss with estrogen, and also protecting against heart disease, diabetes, and now today, in today's world, women's concerns about dementia actually exceed women's concerns about breast cancer. So we're facing kind of modern world with diseases whose rates of disease accelerate after our ovaries quit functioning. Menopause, very simple definition, it's a year without a menstrual period. In fact, it's preceded often for 8 to 10 years with hormone chaos. And we do deplete the population of eggs in the ovaries. Many times women will say, well, if I've been on the pill and I didn't ovulate for 10 years, do I have more eggs left over? And the sad truth is no. The rate of attrition of those little eggs inside follicles is not changed by not ovulating. So there's a whole research, by the way, at the Buck Institute over in Marin County on exactly this, a whole institute on ovarian aging. Very fascinating work going on there. Just a caveat, change of life babies, they do happen. They're not common, but the highest incidence of elective termination of pregnancy is in the ages of 15 to 21 and age 40 to 51. So kind of interesting public health data. Women can still get sexually transmitted infections in menopause, just like younger years. And a lot of my 50-something-year-old patients who've gotten divorced are just shocked when they get herpes or something. And those women didn't grow up using condoms for every interaction. Not that condoms prevent everything, but it's important for women to realize that we have to act like younger women to protect ourselves from sexually transmitted infections. I already mentioned the joint stiffness and hot flashes and often mood challenges and insomnia that go along with these declining estrogen levels that persist. And the question I have is, how many 30-year-olds imagine what life might be like after 50? Of course, most 30-year-olds have a mother who's in her 50s, most, and so they kind of think about their mom. But it's good to think deeply about myself as a woman of a certain age, because I'm going to have the same body I have now. So if I'm going to live 30 more years after menopause, maybe I'll pay more attention to my self-care. Here's a curve, a data set I came across 2 years ago that was part of an article actually in the medical journal of American Medical Association. And it was written by an author who's pleading with doctors to please pay attention to what we've created, because what we've created, this was 2016 data, is by the millions women who live to be frail and disabled and finally dying by 100 and something. So what you and I want is, if we have a long lifespan, we would like to live it to the fullest and frankly, have a very short period of time of the dwindles of loss. So my contention or my belief is that it is now, when we're younger, when we're healthier, that we're going to be in that state, so that we're not going to be part of the millions and millions of 70 and 80-year-olds and 90-year-olds now who are frail and not able to live independently. This is another curve from that same paper by Neil Barzilai in JAMA that just shows the population of women by decades that made up that other curve that we just saw. And you can see relatively few, but still, almost 20 million women who are 54 or younger. That's a lot of people with a disability. But then you go up into the purple. This is 55 to 64-year-olds, and now 65-year-olds. And of course, as we get older, we can always look at our age and think, oh my heavens. And again, this data set is projected to 2020. Well, we're already at over 85 million American women who are disabled who are over 75 years of age. So I find these statistics very upsetting because I wanted to be part of a healthcare system that helps preserve wellness and quality of life. So as I said earlier, what really distresses women today is the possibility of losing their mind, losing their cognitive faculties. And again, that's a huge part of living independently. Um, so Alzheimer's is kind of on everyone's lips. What this pie chart shows you, the 33% in the blue, that's men. This is of dementia diagnoses. 1/3 are in men and 2/3 are in women. And some of the researchers in this area are long-term colleagues of mine in neuroscience that I've met and stayed in touch with through the Menopause Society. And in fact, this slide I borrowed from Roberta Brinton, whose name is down there, 2018 NAMS, that stands for the North American Menopause Society meeting. So when you're active in a field and you read the literature, it's quite concerning because when we think we can prevent dementia in women is to avoid prolonged periods of estrogen deficiency in the brain. So there's a lot that you can learn, and we know the metabolism and what goes on in the brain that causes the brain to shrink and probably is contributing to the acceleration of inflammatory plaques in the brain. So by this point in the chat, like maybe we know so much, how come we don't prescribe more birth control hormones? And in menopause, why doesn't every doctor sort of offer women estrogen as soon as they start to have symptoms? Why not? I mean, if we can follow women carefully and we are confident that overall it's a benefit, but of course, I live in the same culture you do. And so I know there's a lot of confusion and consumer fear, the desire for natural and mistrust of medical doctors. That's pretty painful, but that's certainly accelerated in the 40 years during which I've been part of this community. Even though people fear cancer, dementia, stroke, and heart disease, they would like a pill or a trip to a medical spa and sort of do away with the risk magically. And of course, as I said earlier, a lot of this is lifestyle. And all those little sand grains of time of my lifestyle add up to effectively my better health or my not as good as I would like to live. I try to emphasize family history as a motivating part of our self-care, but I also appreciate the fact that, I'm not going to have the lifestyle of my mother, who at 70 became pretty sedentary and she was depressed, she was isolated. We know those accelerate the risk for dementia. And she'd also never taken estrogen because it wasn't natural in her view. And I was not a gynecologist yet when she became menopausal. I was just an undergraduate at Cal Berkeley. But, these are things that I guess I was a graduate student then. But in any event, the most important thing is that we take a lesson from what we've seen. My mother died when she was 86 of dementia. And it was heartbreaking because before 75, she was fun, funny, bright, scintillating, fantastic pianist. And to watch her life for the next 11 years become so limited was, I think, for me, very motivating. So, as I get older, I'm up in the exercise. And of course, I teach this for a living. So I got to do what I say, not just pretend. So it's got to be possible or patients aren't going to believe me anyway. So anyway, I think what's important is to see the negative effects of the internet and appreciate just how much gossip is there. I say jokingly, in my next life, I'll be a hairdresser. So my clients will believe what I say. But most of my patients don't know basic biology and the physiology that shifts in menopause. I mean, why would they? They didn't go to medical school. But again, our culture, our norm is to be kind of like driving the car, but never look under the hood. Medical science evolves. It's pretty tough to keep up with the burgeoning literature. So I think a lot of doctors just kind of give up and just provide the standard of care and the algorithms that our societies produce, which are okay, but it's not the same as having an active discussion and struggling with concepts and evolving ideas. And then let us not forget, there is this fear of liability. It's very, very rare for a physician to be sued for something he or she did not prescribe. They are sued for what they did prescribe. So, as I say, the public confidence in medicine has gone like this, from a lousy 60% in about 1975 to an even lousier 37% as of 2010. That's very discouraging. I'm not going to spend a lot of time on nutritional supplements, but just in short, they do not prevent osteoporosis. As far as we know, as much as we like CoQ10, if you have untreated high blood pressure and unacceptably high cholesterol and elevated inflammatory markers, CoQ10, vitamin E, fish oil does not significantly alter the pathogenesis of your risk for heart disease. We know from many studies that all the kale and all the calcium supplements do not prevent osteoporosis. I take care of many yoga teachers who 20, 30 years ago were hoping that yoga would prevent osteoporosis or osteopenia, bone loss. It doesn't. But this is where finally our communities have come together and we're a much more integrated community of practitioners. And there really is no supplement that helps us lose weight or is a miracle of the skin. So why people are unfortunately avoiding estrogen still, even with the fear of dementia, is in this slide. So I'm going to move us over again so you can see what is here. This curve, which shows less invasive breast cancer, is from the famous study that was incorrectly reported that said estrogen causes breast cancer. So here's estrogen and here is placebo. So placebo means nothing. So these ladies in the dotted black clearly, unfortunately, had more breast cancer than the women on estrogen alone. The orange line is women who had a uterus and were on estrogen with this one progestin called medroxyprogesterone acetate. Well, who cares? Details, science, boring. Well, I care because this progestin I never prescribed, but mostly no one prescribes anymore because of the fear that was generated. The absolute risk here turns out to be very small. But what was important is the women who got breast cancer who were on this drug had worse outcomes. But I just am sad every day because every day one woman or another is here because she's afraid of breast cancer and her doctor at whatever Kaiser locally said you shouldn't take it. So here is the long-term presented a different way. These are the estrogen only incidence of breast cancer, but this slide includes estrogen only deaths from breast cancer, which is down here. And again, this is women on nothing. So not only was the incidence lower, but the death from breast cancer was lower. And this line is death from all causes after breast cancer is lower. So this is the important takeaway from why aren't all doctors more favorable towards estrogen? Because doctors think like the public, which thinks the orange line tells the story. But the orange line only tells the story of one particular agent that pretty much no one ever uses anymore. So here we are, natural is best. Yet, naturally, less than 5% of women over 80 are healthy and vigorous. One of the homework assignments I give my 45-year-olds And why I do it at 45 is because I say optimistically, you've lived about half of your life. And so this is the first half. Now I'm heading towards the second half. So between now and next year, if you can, think of 5 women over 80 in whose bodies you'd like to live. Because that little assignment makes you pay attention to aging and what I want to do with my aging. And if we're lucky, we'll get to have a nice long life and do interesting things and help nurture others who need our help. But the other brutal truth is that osteoporosis is inevitable if we live long enough in an estrogen deficient environment. The other thing that becomes unfortunately more and more inevitable is obesity, diabetes, and heart disease in women after 60. So, why is that? Well, part of it honestly is kind of in our genes, probably for survival. And remember, we're the team that had to nurse the babies and carry the pregnancy. So we are a little more efficient at storing calories. Oh, good. On the other hand, when we're done with reproduction, that efficiency is kind of shooting us in the foot. So I want to just say that in my view, living kind of like a natural woman, which is a lot more vigorous and a lot more active than most women are, is definitely the way to go. But we should think very deeply and think about the details about how to live best. So I put a couple books up here. This woman, Lisa Mosconi, is a neuroscientist, and her work is all about women and brains. And you can see the subtitle here, Groundbreaking Science Empowering Women to Maximize Cognitive Health and Prevent Alzheimer's Disease. So this just came out this past March. And you may know Maria Shriver's mother has Alzheimer's, and she's become quite the advocate along with Lisa Gibbons. But the important thing for us as individuals is this woman went to the effort, Dr. Mosconi, she took a couple years off of her directorship of the Women's Brain Initiative and got a master's in nutrition to really feel confident herself. What is the best food for your brain? And then she wrote X Brain, which is about the female brain in particular. And the first, I'd say 25 pages of the book are all about hormones in the brain. The other book I have here is Estrogen Matters by Avram Bluning and Carol Tavris. Super good book. It goes into all the details of why taking hormones in menopause improve women's well-being and lengthen their lives. This is true, not hype, without raising the risk of breast cancer. And that is also true. And you just saw the data yourselves. Not only did they not have an increased risk, they actually had decreased risk, and they certainly had better survival. So in summary, this is my view of women's health today. It's a combination of many things. It's what we chose or what we are choosing in our reproductive years. It's the community of people and friends. Relationships are a major marker as we age of health. It's interesting. I've actually known this since I was just a wee little medical student. We used to do little diagrams of the social interactions of these old people on whom we made house calls starting my first year medical school. So it's very interesting when you pay attention to public health. A big part is community. A big part of our community often comes from our career, the people we work with. The pandemic has been really hard on relationships. The woman I saw today who's a writer, she just misses the sort of think tank atmosphere of her office. They're probably going back in January, but in the meantime, she loves her husband, that's good, but it's not the same as all the friends and the friendships that she has through her work. And then there's the family. Do we come from a healthy family? In fact, sadly, most people come from a pretty dysfunctional family. Some parts are good, some parts not so good. So how we figure this out and balance taking care of them and taking care of us. And then, of course, I put dementia fear. This is an increasingly important part because this woman who's the writer, her mother-in-law was in an accident, and she took a good part of her office visit to tell me that they think she was in the accident because she didn't process the road correctly. It was a single car accident. Um, and she's been quite demented. And she lives in New Jersey. So, this is the sort of thing that um, obviously that's not her biologic mother, but the fear that we would still be driving a car when we really shouldn't be is one of those things that if you've had elderly parents or grandparents that don't want to have their keys taken away, these are very tricky things. Chronic illness can take a big toll on us. Um, Obviously, we all know somebody who's had long haul COVID, but there are many things that came before COVID, um, whether it's heart disease or diabetes. And then because we've done such a good job treating so many cancers, we have many cancer survivors who need specialty care and specialty follow-up, and concerns, if it's been more than 20 years, about a second cancer that may be a little higher risk because of the treatment for the first cancer. And then I put this little afterthought down here because without sex, I don't know if I'd have a job. But on a serious note, this is a part of balance in women's lives that I think goes kind of unspoken and unattended to. And I've always been a fan of traditional Chinese medicine and Ayurveda, where they actually make quite a point of the integration of your sexual energy with your total chi. And is in circulation sex, meaning it involves the heart, the circulation, as well as your sexual organs. So back to kind of what I presented before, we know that your lifestyle really builds the foundation of your health. And probably 70 to 90% of our outcome from, those little sand grains of daily living become the foundation for health and responding to whatever our individual genetic risks are appropriately. And I like to put in a plug for really being active in designing my self-care so that I will create choices that really meet my individual needs. Put myself in the schedule. I get up at 6 just so that I have 2 hours before I need to leave the house. So I have time to exercise, do yoga, walk the dog. And, that wouldn't happen if I didn't put myself in the schedule. And then, of course, a mindfulness practice is really the antidote for losing sight of yourself. And these old-fashioned breathing yoga type practices, if you don't have one that's working for you, don't give up. Keep practicing, because these ancient teaching principles are very effective, but we have to practice it enough it doesn't seem too weird. And then participating consciously, like, just say no to the extra chocolate chip cookie. Well, I don't need it. It's a desire in the moment, but it doesn't really serve me. So I'm just quietly not going to grab it. These are those little moments. That to me is a mindfulness moment. And with a lot of my patients, I just say mindfulness at meals and in between so that we don't lose sight of our self-care goals. And of course, again, the culture is not making it any easier with this. But when you're connected to other people that you love, who love you, you feel a sense of meaning in your life and purpose, then I think we can kind of keep that energy of self-care going. And this is kind of my final ideal view, that we are part of this very large constellation of health. The community of caring and connection, the soil, the water, the air, how we're learning, growing, and hopefully transforming both ourselves and aspects of our culture that are not very healthy. And then keeping my whole person view in mind. So I've gone on a little longer than I expected, but I want to open up to all of you and let you ask questions. Thank you to you.
You mentioned COVID long haul survivors earlier, and there's a question here about whether, it's disrupted so many things in health and wellness. Is there any reason to believe that it could also affect reproductive health, especially if one is a long haul survivor?
Well, happily, we're not seeing any indication that COVID impairs fertility. The American College of OB/GYN, if you want updated information, it's open to the public. acog.org has tremendous information available about COVID and pregnancy, immunizations and pregnancy. And by the way, encourage all women who want to get pregnant, are a little bit pregnant, very pregnant, to get immunized. Think about it. What does pregnancy do? It's this giant inconvenience that makes it a little harder to breathe in the first place because of the size of the tummy. So be sure that you encourage your friends. The data is more than completely reassuring that it's best to get immunized. And it's heartbreaking. And of course, guess who's been hardest hit with bad outcomes with COVID in pregnancy is minority women, our sisters.
Thank you so much. There is a question that wants to go back to supplements. They are interested in taking collagen orally for hair and nail growth and reducing facial lines. That's what they hear. And is there truly a benefit to taking these supplements? And along the lines of those, there's also a question for supplements regarding inflammation. Is there benefits to taking omega-3, turmeric, ginger, coenzyme Q10 to combat inflammation?
Right. Well, I kind of hinted at this earlier. There's just nothing like exercise and eating a healthy, basically plant-based diet. And when I say plant-based, I'm not saying vegetarian, but the largest portion of your plate is occupied by vegetables. I'm not a big advocate for all the supplements in the absence of a healthy lifestyle. So, the supplement industry is pretty much off the rails ever since the estrogen embrace went down. And I did see a question in the chat before the question about supplements. And of course, what's wonderful is that Twins, the Community Health Resource Center, has brilliant nutritionists who are there full time, who are experts. And I highly encourage you all to call 415-923-3155. It's been the same number since the building opened in 1985. And I sat on the board to establish the Community Health Resource Center as a free service to the community and pay what you can. But the details really about ginger, curcumin, all these things, yes, certainly curcumin is an antioxidant, but I don't know if it'd be spitting in the ocean if the rest of your lifestyle is not very healthy. So I did want to answer the question in the chat, which I think is super important, which relates to how do you bring up estrogen with other doctors? So I do have, I think I left it in here. So here's a slide from a doctor talk I gave, trying to motivate doctors to open their closed minds about estrogen, meaning women are worried about dementia. Do we know all the factors that increase our risk for dementia? And so what can we do about these risks? So first of all, of course, educate ourselves. This little line in here about that mentions telomeres, what's really impressive is telomeres shorten more rapidly in women not on estrogen. Well, that's not surprising because we know that estrogen slows many of the processes of aging. But for the woman that asked the question about how do you bring up hormones to your doctor? So this slide, the top part, once again, I'm doing the estrogen only versus the estrogen with MPA. This is all estrogen by mouth. Another question that was in the chat was about basically route of administration. How should I take estrogen if I'm going to take estrogen? And the healthiest route is not by mouth, which is what this study did. But when this study was designed in the 1980s and basically put into place in the early 1990s, this, 90% of women in the United States who were taking hormones were on either Premarin, if they'd had hysterectomy, or Prem Pro. So that's why this data set is so powerful because this group up here was 12,000 women, and this group down here was 26,000 women. Why? Because most women, barely, but most women had not had hysterectomy. So that's the ancient history, which is ancient because it's really almost 50 years ago, that all this came about. The important thing for us to know today is that the European data of estrogen alone uses transdermal estradiol. So that name, estradiol, is bioidentical. Now, interestingly, in journals, when like the current menopause journal has an article about bioidentical hormone therapy, BHT, well, that's been a buzz marketing and sales pitch for doctors that, in my opinion, do very unscrupulous things, which is called pellets or compounded creams. Really, the only reason to get a compounded cream of hormones is testosterone, in my opinion. There are some compounded creams for estradiol or estriol for vaginal, that's fine. But for actual hormones that are going to affect your bloodstream and have an impact in your health, you want data like this kind of data. So we followed these women. This data set that I'm showing you is from 2013, and it's looking at women after 11 years of use. So my objection to mail away, fly by night, Women's International Pharmacy or College Pharmacy in Texas, who knows what's in those products? You have to take it on faith. There's no package insert. There's been no FDA supervision. So it's really an abuse of trust. And just from doing hormone levels on women for years, I can tell you the quality and the actual level in the bloodstream has varied tremendously batch to batch in these patients. So I'm careful. I order ultrasounds. I'm monitoring for uterine cancer, but that's what the article that came out in yesterday's menopause journal is, just more tragic information about women on pellets and other completely unsupervised hormone production, hormone products that are called bioidentical. Well, the ingredients that they put into the little mystery pellet are, but it's way in which your body absorbs it, the way in which it may stimulate your breast or your uterine lining, which is where uterine cancer comes from, is highly variable. So I love data like this. I can tell your doctor, and this is the approach I use with patients because I see a lot of Kaiser patients and I see a lot of patients who have other primary cares. And unfortunately, I can't do what I do and participate in any health plan. But I showed them the actual data because this is the basis on which I counsel patients. All causes of death, all cancer deaths, colorectal cancer, all types of cancer, all fractures. And then this one, which is really pretty impressive at the far right, 26% less diabetes. Well, what's killing American women? Probably more than any single thing. It's hard to know, is it diabetes or heart disease or a little bit of both? But that's it. Somewhere in the neighborhood of 65 to 70% of women die of those causes combined. And then we're now seeing Alzheimer's as a cause of death, rising to, sadly, about 1 in 5 women. So, people fear breast cancer, but less than 2% of women die of breast cancer. And although, I've been involved with breast cancer for years, so I hate the 2% because it feels like we should never die from breast cancer. But with mammogram screening, early detection, and appropriate treatment, that's not going to shorten our lives. It's these other things. So if you look at just, the bean counter approach, like what's going to keep women out of the hospital and out of bad health, well, it sure looks like estrogen wins. And again, this is women who started between 50 and 60. That's off the slide from this presentation, but these are the sorts of knowledges or information that we can have. And I just go back with other doctors. Most doctors have never seen this picture. And so, by the way, anyone who wants these slide sets, I told Twen that you're welcome to have it. She'll email it to you. These are not PDF protected. So if you want to copy this and just print out that picture, you can click on it and you can print it out. You know, just paste it onto something and you'll have that picture. So the important thing though is that you've informed yourself, you've paid attention. I do think reading those books is very, very helpful because they are full of data in a way that's very compelling, and they're not fluffy authors. Abram Blooming, the one on why estrogen doesn't cause breast cancer and it results in better health, he's an oncologist at USC who specializes in breast cancer. And the other author, as you know, Lisa Mosconi, she's a neuroscience person who runs the Women's Cognitive Center at Weill Cornell Medical Center. So these are not flaky Hollywood, you know, TV doctors making a buck writing a book. These are sincere clinicians who want to, you know, reverse a trend, which is very concerning. So again, in the slide set, and I just brought this up so you all can see it, these are my suggestions for sort of baseline screening tests so that, you know, now colonoscopy, I put in the new recommendation, which is the first at age 45. And, you know, a lot of women have never had an EKG or a chest x-ray. Again, depending on where you grew up and were your parents smokers or were you a big smoker, we may do these at earlier ages. But anyway, soon genetic screening, I think, will become an offered part of precision medicine. I had a patient today and I said, you know, the problem with that is that we don't know what to do with the data yet. So there, I see something more in the chat.
Yeah, and before you move away from these slides, I know someone in the chat is asking about whether the studies involving estrogen are broken down into ethnic groups.
You know, that is in a different, the Women's Health Initiative has a relatively small percentage. I think it had about 8% African American, but a much better data set to answer that question. And again, these are public data sets, and it's kind of fun just to go poke around on Google, put in SWAN. It's the study of women's health across the nation. And SWAN is one, and the other is NHANES, the National Health and Nutrition Study. I don't know if you've seen that, but anyway, these are fantastic data sets, and they have very large distributions of minority populations. And it's actually between SWAN and NHANES that I put together that slide that has this, what I call my sad bars, where all bars track upward from 1980 to 2000 to 2020. Very, very upsetting, but the minorities track even higher. By the way, there's a good question here about from Luann to everyone about contraceptives for women between 15 and 30 causing an increase in sex binding globulin, which suppresses libido. Well, contraceptive hormones do two things that suppress libido. One is directly when you shut down ovulation and you make the ovary less active, part of the ovary was making the estrogen and progesterone, and that declines. The other background part of the ovary makes testosterone. So normally about 1/3 of our testosterone comes from our adrenal gland, 2/3 comes from the ovary. So what happens when you put those little ovaries to bed to sleep with birth control pills so you don't ovulate and get pregnant is your testosterone declines. And in addition, what Luann has said is also true. And this sex hormone binding globulin just comes trippingly off your tongue, but that's a protein. I describe it like it is a catcher's mitt and it catches the ball in play, which is your hormones. And so it does that to testosterone, it does that to estradiol. The big deal here is that when these hormones are locked up in that catcher's mitt of the protein, they can't get into your brain. So what we see in new relationships in young women, usually it doesn't matter because there are other aspects of the brain that overcome that. But we have data that show same relationship, different age groups, but after 5 years, same partner, declining libido. So it's very, very interesting. Of course, we have that data. What do we do with it? Well, for the woman that comes in and doesn't have a very good desire, yeah, I'm not getting pregnant, but so then we discuss maybe she is the woman that would like to have an IUD for a while, as long as she did not have disabling premenstrual syndrome or other concerns. Terrible cramps, usually the IUDs that I mentioned that have the little bit of progestin, levonorgestrel in them. I mentioned the family, Skyla, Kylena, Mirena, Liletta, a little quartet there. They have different doses, so you can try a low dose IUD. But anyway, those, if you have bad cramps, usually make the cramps less bad. I did want to get to the question about 6 years into menopause, still having hot flashes. It's not too late to get on estrogen. In fact, the women in that clinical trial that I just showed you all that data, that was starting within the first 10 years, the first decade since the final menstrual period. So the American data set relates to you, Jen. And so I would say, just because, why not do the healthiest, which is the transdermal? Although, if you had been on birth control pills until menopause and then you stopped the pills and now you're suffering, those women are kind of road tested for low risk for blood clots and strokes. So, the average woman would be fine on an estrogen pill like estradiol, bioidentical. There are combination pills if you have a uterus that have a little estradiol, little norethindrone. That's a great product. It's been studied to age 85 in the United States, and the Danish osteoporosis trial used that same oral estradiol, oral norethindrone combination. So you can tell if you see somebody who specializes in menopause, they've got a lot of tools in the toolbox, and they won't just go, well, I don't know, just take a little estrogen. They'll have all different recipes to offer, just like Julia Child in the kitchen, depending on what you want to cook up. But what's important is that we speak up and advocate for ourselves. And it's very depressing right now. Women kind of have to get in the face of a lot of clinicians to say, no, I'm miserable. I'm not sleeping. I know it, the sleep, the insomnia, all these hot flashes come from my brain. They are signals of my brain distress. I read Lisa Mosconi's book, The XX Brain. Doctors hate this, by the way. You bring your book in, you say, I read the book. Have you read the book? No. And so, doctors roll their eyes, but you're correct. You can print out stuff all about dementia from just doing a Google search, that our risk for it is accelerated being off of estrogen. So now is the time. You're a young woman in menopause. So I would be very bold in, kindly, but being persistent about the fact you are a symptomatic woman. All symptomatic women, even in the most rigorous kind of anti-estrogen algorithm, are candidates for treatment. The only woman who's sort of tricky in today's paradigm is actually the woman who has no symptoms. What do we do for her? Well, she's still going to be at risk for shrinking brain volumes. That's what we know. In estrogen deficient brains, the anterior cortex shrinks, we lose volume, and we lose brain volume at, guess what, about the same rate at which the brain goes to utilizing fat as a source of energy. Because normally in estrogenized brain, 99% of our energy comes from glucose. And in an estrogen deficient brain, that switches over. It's pretty fascinating. Why does that happen? I don't know. That's where the neuroscientists are digging in. Why? But I do know that it's a consequence of low estrogen, which is not good for my brain or anybody else's. And why it's not part of gynecology, it's part of neuroscience. But the neuroscience doctors, neurologists, that's not what they do for a living. So what you and I are dealing with is the same societal problem, which is silos of knowledge. And it's really tough to kind of stick one's neck out like I do and say, well, I may be a gynecologist, but I give grand rounds to the internists because they need to know this. And mostly they're grateful. So anyway, I really encourage all of you to speak up in your own behalf and not get turned down by a clinician who just doesn't have time to go into detail. You can go to the North American Menopause Society website. It's actually menopause.org. That'll be the North American Menopause Society. and you can go to find a provider. We put together all the North American Menopause Society certified menopause practitioners. That's what CM P is after my name. And you'll see somebody, you put in your zip code and how far you're willing to travel. And these names will drop down of clinicians. Often they're nurse practitioners or physician assistants, but we've all taken the menopause certification exam put out by NAMS that really emphasizes the knowledge base to be certain that we're optimally serving women's needs and doing good for them, short and long term.
On that topic, a participant also wants to know when one goes on estrogen, what is the time frame for that? Is it long term?
Well, I say that it's something we assess every year. And of course, once you feel fine and you're not having any issues, like, why would I stop this? I don't have testicles, nothing's going to make these hormones that have helped me go back to sleep and not have dry eyes and not have sore joints. If I stop my estrogen, and that's really annoying. I mean, I have to buy my estrogen, but you know what? I had to buy birth control when I was younger, and what's the difference? It really isn't very different, but it gets it annoys me because, of course, the culture doesn't really support women in staying on hormones. But I just say we reassess every year. For example, a sad topic, breast cancer. So I have patients now and then who have an estrogen receptor positive invasive breast cancer. Well, depending on details, the majority of them, we will stop their estrogen and we will do other things to try and keep their brain healthy. Paroxetine, Paxil is a pretty good hot flash, second best. Nothing works as well for that as estrogen, but Paxil works pretty well. I had a patient a couple weeks ago, and Paxil wasn't working well enough. We added a little bit of gabapentin at night, and now she's much, much better. Well, in the ideal world, in 5 years or so, she may be back on estradiol. But for now, what's most important is that we know that this breast cancer is completely cured. And so, these are the situations where there are other ways to take care of symptoms. Unfortunately, her joint stiffness, she's just doing a lot more swimming and less running because her knees and her hips just can't take the pounding. So these are, lifestyle adjustments, but, she's got kids in their 20s and we're all motivated to have her be healthy. So these are tweaks where certainly once the mammogram found this tiny little 2 millimeter, smaller than a peppercorn abnormality, but these are adjustments. So it's an annual decision, or like in her case, I think that was an interval mammogram. I had seen her like 9 months before, and so then we stopped her estrogen. So we individualize depending on things. There's a whole discussion with heart disease and transdermal. So the official is that estrogen through the skin prevents heart disease in women who start between 50 and 60, just like estrogen by mouth. We've done head-to-head clinical trials. We know this is true. Cardiologists think all estrogen is Premarin, the oral stuff that does increase your risk of clots and could increase your risk of a heart attack. So, I can't move mountains. I do share the data, and I also hold my patients' hands during periods of time where the cardiologist is trying to make up her or his mind about the data that I've shared. So, it's a collaboration in clinical care, and those are fortunately rare. But anytime we have a question, of course, doctors usually take women off of estrogen. So it's a continually reassessed opportunity.
We have a question here from a woman who's reproductive age but experiences very bad cramps where her day will stop And she also has an IUD, so she was prescribed birth control pills to help with cramping and um, was informed that it would also help with potential scarring that could be happening. Could you help her understand the cause for scarring and how birth control pills can play a role in that?
Sure. Well, of course, I'd love to know what IUD, did they take the IUD out? I hope.
I I don't think so. I think that it's at the same
Left it in.
time.
I mean, if you take birth control pills continuously, you don't have a period and you're not having cramps. I have a few patients, by the way, who had IUDs put in college. They come back, they're having, terrible acne and bad cramps, and their menstrual period is a flood. Where when they were on the pill, they had a little drop. Anyway, so I've had a lot of young women I put back on the pill and let them think about their IUD for a while. I don't just remove it. Again, because for whatever reason she wanted it, but the patients I've had who had the Paragard, I'll name it because that's one without hormones. That's clearly the one that's associated with the most cramps and the heavier bleeding and just ferocious pain for a lot of women. Um, and so you put them on continuous pills or continuous NuvaRing, and as long as they're not cycling, the IUD just lives there quietly. So their skin gets better and the cramps are better. And again, this is one of the tricky things when women have never, I have patients that were put on birth control pills because they had terrible cramps from their pediatrician, like age 14. And I'll see them when they're, 21 and their college roommate has an IUD and they thought they should get an IUD. And I'll say, well, before you do that, you might want to see what your natural cycle cramps are like, because the IUD that was being offered was the Paragard. That's just the basically copper T. By the way, the copper is in the stem, not in the T bars. Anyway, and sure enough, when she stopped her birth control pills for 3 months, her cramps were so bad with no IUD, she said, oh no, I'm not going to do that. So that to me is a preferred way to analyze that, is to do the trial, stopping the pills, not putting anything in, just, how bad is nature for me? And we have a terrible word for this in gynecology. We call it essential dysmenorrhea, which is like the dermatologist telling you you have some rash and they say, oh, you have dermatitis. It doesn't say what caused it, doesn't say what we should do about it. It just says, oh yeah, something's wrong with your skin. Well, essential just means we don't know why you have terrible cramps. What's interesting is we followed these young women now for many, many years. The vast majority have very normal fertility and they don't have any discernible reason to have bad cramps. So it's very frustrating. You can do MRIs in these young women. We don't do many, but we've done some. Magnetic resonance imaging is a lot more detailed than an ultrasound. Endometriosis is the usual consideration that we're sort of looking for. It does not show up on ultrasound the vast majority of the time. So you get an MRI, you still see nothing in the vast majority of women with, quote, essential dysmenorrhea. The beautiful thing is birth control pills or the birth control ring really do abolish it. One, probably the newest pill on the block, many of you may not have heard of it. It's called Slynd, SLYND. It's a 4 milligram drospirenone only. Well, drospirenone is what's in Yaz and Yasmin birth control pills. Yasmin is a 30 microgram ethinyl estradiol. Yaz, the little short name, has only 20, the lower dose of the estrogen. I mention those too because many young women have liked those pills in the past, and for one reason or another, like if you have a migraine with aura, we don't want to give you ethinyl estradiol by any route, by mouth, or like NuvaRing has ethinyl estradiol because it can slightly increase your risk of a stroke. But you could take the drospirenone. So now there's a drospirenone only pill for those select women that want to avoid some of the side effects or the risks of the ethinyl estradiol that basically is the estrogen in every combination birth control out there. So, people can hate pharma and be annoyed at organized medicine, but I feel we're blessed in the United States to have such diversity of options that we can offer women to solve most of our needs. But we have to ask.
Dr. Polycove, I wonder if you have enough time to maybe answer just one more question. Well, it's sort of part one, part two, but Elaine in our audience wants to know if there are possible negative impacts of taking estrogen noted from these studies, and also if estrogen is something that insurance covers.
It's great couple of questions. I mentioned potential negative impacts like estrogen by mouth may increase your risk of having thrombophlebitis in your leg, or an event where a clot may have traveled. That's called an embolus. So I'm very aware of the potential side effects, the downside of estrogen, which is why, especially in women in menopausal age groups, like I think we had the Elaine, who was 6 years into menopause, I would encourage her to start with a low dose of estrogen through the skin, transdermal, to avoid those risks. So the major risks are when estrogen is taken by mouth, the blood clots. Other risk, which I alluded to, but I'll speak directly, is about the uterine lining. So those of us with a uterus, we cannot just take estrogen alone in the usual doses that make our eyes feel normal. Tear production is an estrogen dose-related phenomenon. Joint stiffness is a dose-related phenomenon. For most women, these ultra-low doses don't do as good a job. They may not do as good a job on insomnia or sleep disorders. So we have kind of a stepwise selection of patches in all these little doses. And so the important thing there is once you get to a reasonable dose, we want to be sure that we're keeping the uterine lining thin. And that's where progesterone or a progestin, meaning a synthetic progestin, come into play. And one of the things I do, I have this little card in my pocket that I show women, and I show them down at the bottom are the patches with all these different doses. And then you can't really see it here, but I drew a line that goes about right here, which is where the estradiol level is in men every day, as long as they have testicles. So what I'm hoping to impart with this is to say, we mostly offer very, very low doses in the transdermal gels. That's what's up here. And it isn't until you come into the patches that you get near the average estrogen of young women, which is about 100. So the average estrogen here for the highest dose of patch is about 85 to 90. So we have the flexibility of dosing. And so we usually start low. We usually go slow because if women have been estrogen deficient for a long time, very often the first thing they have, way before they have a whole lot of benefit, is their breasts are a little tender. And in our culture, what do you think they think? Oh my God, it must be cancer. So no, it's increased mammary artery. It is probably dilated, more blood flow to your breasts, but these are the realities in a fear-based culture, and one that, every care provider is not optimally educated. So, but I definitely would say to assess one's risks, you want to be sure you have had a recent mammogram and a good clinical breast exam, that you're not having any abnormal bleeding. We never start estrogen in a woman who has undiagnosed vaginal bleeding. These are written in stone in our society, and I'm sure all doctors are aware of this. But again, we, the patient, we, the consumer, have to report in, hey, I did have bleeding. It was only after sex, but well, it actually happened another time. Anyway, so, when you talk to patients, sometimes you get a little more of a picture of what's gone on. Standard care for postmenopausal bleeding or out of cycle bleeding in the menopausal transition is an ultrasound in most private settings. Kaiser is not big on ultrasounds. They'll often just do uterine lining sampling or endometrial biopsy. So there is a little difference in care depending on your health insurance. But again, I encourage people to go to the menopause.org website and look at the certified menopause practitioner list that's within however many miles you're willing to travel. And you'll probably find somebody who's very well informed, who's in your plan, and who knows this information.
Thank you so much for your thorough direction in this discussion, Dr. Polyakov. I especially enjoyed, and I am sure that everyone appreciated you sharing specific cases from your practice as well, really just to show the diversity of women that you see and the kinds of questions that come along with it. Thank you, everyone, and have a wonderful night. And tomorrow's Veterans Day, so please have a safe and wonderful holiday.
Thank you all. My pleasure.
Thank you, Dr. Polyakov.